Necrotizing fasciitis in cardiothoracic and general surgery. Necrotizing fasciitis has a high mortality of 25 to 35%. Mortality is directly proportional to the time of intervention, and the purpose of this presentation is to review the microbiology, pathophysiology, and diagnosis and treatment of necrotizing fasciitis. It was diagnosed in 1871 as early by Dr. Joseph Jones and Dr. Jean Alfred Fournier, who diagnosed the presence of Fournier's gangrene, and Dr. Wilson coined the term necrotizing fasciitis. So, necrotizing NSTI stands for necrotizing soft tissue infection. It's a rare disease. Incidence is 1,000 cases per year in USA. Increasing incidence is 1980 to 2000. Prevalence 1 or 2 cases for average practitioner. So one of the common area is the scrotum and perineum, which is called as the Fournier's gangrene, and it can be classified on the depth of infection, like necrotizing adipositis, most common, fasciitis, or necrotizing myositis. Microbial causes can be divided into 3 types: polymicrobial, monomicrobial, and vibrio-venlificus. The type 1, the most common in 55 to 75%, it's a polymicrobial. Clostridium perfringens is a rare cause of NSTI and commonly seen in perineum and trunk. Immunocompromised patients like diabetes mellitus and peripheral vascular disease can commonly have. Also common in IV drug use and no inciting event in up to 20 to 50% of the patients. The microbiology and risk factors of type 1 include immunocompromised patient, obesity, chronic renal failure, HIV, alcohol abuse, abscess, IV drugs, trauma, insect bites, surgical incisions, indwelling catheters, chicken pox, perforation of GI, and spillage of Clostridium septicum. The type 2 infection is caused by Streptococcus pyogenes and can survive in macrophage. Staphylococcus aureus, there is association with toxic shock syndrome. MRSA, soft tissue infection cultured in up to 40% of necrotic wound, IV drug abusers. Healthy young immunocompetent host, location in extremities, and trauma or operation. Type 3, least common type, is Vibrio venlificus and caused by skin breaks, warm sea water, coastal communities. Risk factors is chronic HBV and fulminating cold. Pathophysiology, the invasion of subcutaneous tissues by trauma, perforated viscous, production of toxin, tissue ischemia, thrombosis, perforation of skin vessels from local hypercoagulable states, prevent the adequate delivery of antibiotics, liquefactive necrosis, systemic illness, extent of infection larger than that is suggested by the findings, and infection and spread 1 inch per hour with little overlying skin change. Differential diagnosis could be cellulitis, adipositis, myonecrosis, non-infectious fasciitis, phlegmasia, cellular dolens, and mixed edema. Patient present with a history of trauma or skin break 48 hours before symptoms, and local erythema, swelling and pain beyond the apparent confines of infection, and normal skin appearance in early stage. Crepitus or skin necrosis can be seen. Plain X-ray is a poor screening test. CT scan is more sensitive than and it will show inflammatory changes, gas formation, facial thickening, and MRI sensitivity of 90 to 100%, specificity of 50 to 85%, prohibitive in critically ill or unstable patient. Operative exploration is the gold standard of modality for diagnosis of NSTI. Dish water or foul smelling discharge can be seen. with necrosis, lack of bleeding, loss of normal resistance to fascia. Biopsy from the interface between the live and dead tissue is rarely indicated. Surgical debridement is the cornerstone of therapy. Delayed surgical debridement for more than 24 hours is associated with a nine-fold increase in mortality. Wide excision to compromise healthy bleeding tissues. Serial debridements. Amputation is a consideration of IV drug abuser. Diverting colostomy for perineal and perianal anesthesia, and open wound wet to dry dressings, and wound vac dressing is a negative pressure dressing that can be applied, and skin grafting can be done after the debridement and when healthy granulation tissue is appearing. IV antibiotics can be used, and it's a mainstay of the treatment, and depending on the culture and sensitivity, the most commonly used is vancomycin, linezolid, daptomycin. Clindamycins can be used for anaerobes and quinolones for gram-negative. Clindamycin for gram-positive. IVIG binds staph, streptococcal toxin, and limiting the surgical inflammatory response syndrome. Critically ill patient from strep and staph can benefit with that. Other thing is hyperbaric oxygen, and it's controversial, and it can be used in some conditions. So morbidity and mortality depends on the time of operation. It's a more critical determinant depending on the age, comorbidities, especially diabetes mellitus, shock, hypovolemic, cardiogenic, and it could be like septic shock, ARF, and coagulopathy may be present. Morbidity as high as 82%. Amputation rate is 15 to 30% if occurs in the limb, and especially if there is vascular compromise or peripheral vascular disease, or in the IV drug abusers. Complications of nosocomial infections, respiratory tract failure, ARDS, and seizures, stroke, cardiac arrest, and it can happen in mods as well. So future efforts monitor the changes of microbiological causes, enhance imaging techniques for early detection, and role of adjunctive treatment has to be analyzed and worked on. Thank you.